be talking about, as advertised, we're going to be talking about medicine supply and medicine procurement. Thank you, for joining me on the stage.
Good evening, everyone. I do
hear me?
apologize. I had a bit of technical issues, and I'm glad that I'm able to fix it. So bear with us. Thank you so much, Tammy.
Yes. Cool. Excellent. We are going to be sharing about medicine supply and procurement. And what we thought we would do today is to look at procurement in different area. Procurement basically in different areas, various sectors of procurement, and discuss various model of procurement in community health service, because they're slightly different, and depending on what, if you remember the first time when we discussed about community health service, we were talking that there are different sectors, and the sector decides what flexibility you have with anything to do with medicine anyway. And so when it comes to medicine supply and medicine procurement, is the same in the sense that what flexibility you have really depends on that. So we thought we will explore that. And if people have questions, obviously they can help us with those questions. We can help with those questions. And we'll consider, obviously, things about access to medicine, quality assurance, and ways people can collaborate and things like that. So medicine supply in various sectors. So like we said, the sector kind of determines how you are able to get medicine. So when we were talking about medicine in the community health service, we said that there are different models. So there are a model in which the community health service stand alone. So they are what we call private provider, like a social enterprise. We have one that they are either attached to a primary care network or part of a GP, what they call GP Federation. We have the ones that are attached to NHS Trust. And we have some that are attached to the council, depending on the borough. So that would determine how people can procure medicine. So for example, the easiest one really is when they are attached to an NHS Trust. As we know, NHS Trust, they have a bit more flexibility and things are a bit more fluid if they are attached to an NHS Trust. So because they are considered as one. And that has its advantage, that also has its disadvantage, but it is, in my view, and obviously, Jen can chip in my view, that is the easiest way to get medicine, because they have an NHS contract in terms of procurement. Most of the procurement is done in bulk, is done with NHS England involvement. They get a lot more discounts. Actually, community health service that are attached to an NHS trust, usually they don't know the difference because they just see themselves as a one big family. So in essence, they don't know the difference. You also have private provider who have an honorarium contract with an NHS trust. That also almost give them the same power as an NHS organization who actually owns the community health service, because of that honorarium contract, there is movement of medicine easily. And to be honest, most of the procurement will be done by the NHS, and it's just about transporting that happens between them based on their honorarium contracts. Whereas I'll share my experience and I'll get thank you to share our experience because it's slightly different. Even though we are almost the same sort of organization, but the way we did procurement is slightly different. So within my organization, before I actually took on the post, we actually were we have an honorarium. Well, I won't call it an honorarium contract. We'll call it a service level agreement with our closest NHS trust that they will supply us medicine, because to supply medicine you have to have an wholesaler dealer license. So they are happy to do it. However, that wholesaler dealer license came to an end and they did not renew their license. What that means for us is that they can no longer supply us medicine legally. And so we had to find other suppliers to supply us medicine. And what we did was to physically go out to tendering, to look for people that can supply us medicine. And for people that are very familiar with the like of medicine distributors or medicine suppliers, so we're talking about people like Alliance Health, we're talking about people like AH, actually supplying medicine. And what that also means is that the discount that we used to get while we were on working with the NHS organization, we didn't have that discount anymore. So because we're no longer considered as within the NHS, so to say. So we had to pay whatever the price of the drug is. Whereas where we got that service level agreement with our closest NHS trust, we get the medicine at a discounted price because they got the medicine obviously at a discounted price. And so what that also means for us is that because we are who we are, not an NHS organization, it also means that we had to almost sign up with more than one supplier, because certain supplier have what we call restricted medicine, and it's only certain suppliers that can supply restricted medicine within the UK. Sorry, within England. Let's leave it like that. So I had to sign up with more than one. So at the moment we got like four different suppliers. What that also means is that for you to pack down medicine, like have a labeled medicine, already labeled medicine, we have to find somebody else who will do that for us, and to do things like anaphylactic kits for us. And then to find somebody who's going to do the dispensing when the patient is going home. Then we have to have another contract with a pharmacy. So like I said, when you don't have that closeness with your it will be if you are in a partnership, obviously, with an NHS organization. So, and that is a known fact. And it's not because they don't want help, it's just because there's a legal requirement around medicine when it comes to supply, when it comes to wholesaler dealer license, when it comes to packing down medicine to do a pre-labeled item. So that is quite key, and that is important when we start to look, because then it helps you in a way when you're writing your policy. It also helps you to inform the staff who are going to be the end points using those medicines, so that they can understand and they can set the expectation of the patient, set the expectation of their service. And you can actually know that, okay, it might take an NHS organization, I'm thinking 2 days, but it might take us maybe 3 days or slightly more. So we plan ahead. And that's really important, because what we don't want is for patients to go without. So we have to make sure that we are in a place that we know what service we can deliver within the legal framework, because of who we are a standalone organization, private provider, or a contract that you have with the NHS. I think I've talked a lot, I will, before I hand over to Jenku, I just want to welcome um, Melvin Smith. Thank you for joining us. Louis B, thank you for joining us. And Esther, thank you for joining us. And Judith has been with us, and Kevin as well. So I've talked to you about what our service look like, as in my service within my organization, in the sense that if I'm within an NHS trust, or I have a link with an NHS trust, I only need to be attached to one place, and I get all my medicine. Whereas because we stand alone, I've got 4 places I need to get medicine for my patients, and that makes it a bit more interesting, so to say. I'll let Jenko obviously tell you about because they did it slightly different a few times
Absolutely.
more than me. Go for it, Jenko. We can't hear you.
Hear me?
Yes, it's better now. A bit louder though.
Okay. A bit louder.
Yeah, better now.
Okay. I hope you could hear me. But so I said thank you very much, Tammy, for setting the scene. But I wanted to sort of dial back a little bit for us to have an understanding. Because when we're having a pharmacy procurement or a pharmacy supply, it's important for you as an organization to know what your pharmacy spec is. What services are you requiring medicines for? And I'm probably coming from an angle of stock medicines, inpatient medicines, clinic medicines, because we know that supply of medicines via FP10 is pretty much straightforward, it's pretty much standard. So it's important for your organization to sort of have a pharmacy spec or pharmacist provision spec. And that for me was the basic standard that we needed to have. So either we were having a medicine supply from an acute, an NHS organization, or from a community provider with an wholesaler's dealer's license, we needed to know what we would want and what we would not settle less for in the nutshell. And yet, Amy, by all means, we've been through various suppliers, and it's important that we understood that as a set stone. And so in our service spec within an organization, it was like my wish list of what I wanted a pharmacy provider to be able to do for us and what we would not be able to entertain when it comes to supply of medicines. So, for example, I put in my pharmacy spec, I wanted, alerts to be communicated on a regular basis, investigations to be completed when there is a, medicines incident. I also put in there, and it's quite a hefty document, so which means that document isn't just reliant on me as a pharmacy expert to be able to complete that. So it meant that I needed to include the various stakeholders like the procurement manager, the finance team, to ensure that we're working together. So initially, Tammy, and I like the way you've explained your experience of pharmacy procurement within your organization. One thing I didn't want within our organization is, obtaining pharmacy medicines from various sources, simply because we run various services and the need and the request and the demand for medicines is quite high, meaning that having to get services, obtaining medicines from various channels without that, support, because I think Temi has got a robust system within our organization. I didn't want that to fall out. So we decided to go initially within the community pharmacy, and the community pharmacy had a wholesalers dealer's license, which means they were able to supply stock medicines. Unfortunately, they fell short when it came to provision of pharmacy over labels, so which meant we had to subcontract that out to another NHS organization. But currently, I think over a period of time working within the healthcare partnership, I've been able to develop a relationship with the acute trust. And now we have when the contract expired, we went through tender. So please, it's important that we go through the process, because Tammy mentioned the whole tender process, and that's to make sure that there's a fair and equitable, positioning of what you require out there. And we went through the tender process. We weren't able to secure a contract through that. So we decided to go with our acute provider, simply because we had been through contracts with them previously. We had various SLAs within the organization with the acute, and it seemed a lot better because we were talking about collaborative working. Last month when we spoke about innovation, we spoke about the innovative way of working and having a pharmacist work as an interface role. So it seemed like a no-brainer to have pharmacy provisions via the organization. So in a nutshell, what we've now gone through is that all our pharmacy provision are being supplied by acute, having a SLA a service spec in place, and having a very detailed contract to ensure that we meet, dot all our I's and cross all our T's. And I mentioned the fact that we needed to have various stakeholders on the table. So yes, I had my wish list, which was my service spec, from a pharmacist's point of view. But I also got the procurement manager to have their own lingual included into it, so we know that we are going through the procurement process properly. Then also, I wanted, from the financial point of view, that are we striking the right deal here? So we went through with the finance team to do some sort of calculations, because you have to bear in mind that, Tammy, you'll probably acknowledge that we are pharmacists, and through our whole years of experience, procurement, finance, and expertise like that, we've probably embedded in our role, but over time you needed that sort of external support. We went through that, and then also to finalize the contract, we went through the contracts team and the strategic team to ensure that the document is well fit for purpose, and both organizations were happy with it, really. So that's where we are at the moment. And also, in terms of the pharmacy procurement, it meant that we also had KPIs that we were measuring, and so far it's been, I think it's been, a better deal for us to go via this route than what we had before. And not disputing the provision before, it just seemed a better contract. Temi mentioned the whole, getting medicines discount. One thing with the acute is that they do have their medicines from a central medicines unit, the CMU, which meant that there were some medications that would come at a much discount rate. So which means within our organization, we're exposed to that. And also we're able to sort of go through the initiative, the medicines value initiative that's been run within the acute. And, we're trying to, also cut costs and ensure that pharmacy provisions or pharmacy supply is also in adherence with the local formulary, which the acute tend to do. So I think that's one of the pros and cons that I sort of identified from going through a non-NHS provider. And it's not, speaking about this in an hour does not quantify the amount of work, the amount of engagement that is required in there. But most especially, I think what we're considering is the patient in the center of it all, ensuring that our patients are getting the medicines at the right time, ensuring that our patients are getting medication that is in line with our formulary. And one thing that we noticed was having the medicines outside would mean that we were having to control it a lot. And knowing in a community health services, the workforce in terms of pharmacy workforce is quite limited. So we needed to utilize all the resources that we had. So meaning the joint force with the acute made it a lot better for us to sort of work together to devise this sort of pharmacy provision. Tammy, I don't know if there was anything different that you have done to be able to ensure formulary adherence for medicines procurement within your organization?
Thank you, Jenkyo. I think medicine procurement is is uh, is always a minefield, and one of the things I realized was, what you were saying, that the medicine procurement in itself, there is challenges. So, and the thing is that with me, I identify the challenge as I go along. So the challenge of, okay, you're not going to get the discount anymore, because I assume that because we deliver NHS services only, we should be exposed to the the we should be exposed to the discounts, but we were not. The second thing is what I said about restricted medicine. So I signed up with one supplier thinking, oh, AH will supply everything. And then AH will be like, sorry, we don't supply insulin. That can only come from Alliance Health. And I was like, oops. So I had to go to Alliance Health. And then when it comes to my services that deals with what do they call them, MSK. And then we realized, okay, we need to get the Depomedrone, which is for the steroid injection. And it's like, oops, you can't get it from AH, you have to get it from Alliance again. And so we had to put in all sorts of form to convince them that we are credible to actually receive these drugs. So there are barriers that has been put there. Sorry. There are barriers that has been almost put there, not necessarily because they're trying to be difficult, but they want to make sure that an authentic person is actually receiving the drugs, and it's not just one random organization. What that means also for us is that impacts on us. And so you almost have to know. And my advice would be, if you're going to get into something like that, to actually speak to someone, find somebody who is been through that process, who can actually say, these are the pros and the cons. Is now that everything is set up, it runs like rail. But at the beginning, it was a lot of learning for me, and I guess it is. But the other thing is that with us beats, the NHS Trust actually did not want to renew their wholesaler dealer license, because we were really the only one they're supplying. So it's not cost effective for them. And that's one of the things about community health service, that because most community health service are small organization, one of the challenges is about the tendering, who actually will be interested in taking on that contract. And that can mean you obviously going through a few tendering to actually get somebody who is interested in that. But the learning is there, and it makes you better, to be honest, because then you get to learn about things that you don't know, and you know how to tackle that next time. It also gives you a bit more exposure about the nitty gritty that goes into medicine supply, and things like that. So for me, it's been a learning, and but I've enjoyed every single one of it. Thank you. The next one is, what is considered when procurement, what to consider when procuring medicine. Just before we jump into that, I don't know if anyone has got any questions, maybe something you've come across during your procurement that you may want to ask, or maybe you wanted a particular drug and they said, sorry, you can't have it because we can't get it, or something like that. I don't know if anyone has got any questions about that. If there's none, Jenkyo, do you want to take the
Absolutely. Can you
what
hear?
is considered when procuring medicine?
Can you hear me?
Yes.
Okay. So, I think I've sort of given an example in a nutshell, what you need to consider. So initially I spoke about having a pharmacy provision spec, but you also need to consider the access to medicine. So the services you're offering, that within your organization. You consider the need for the type of patients that you're servicing as well. Then you also need to think about, when you're thinking about procurement in the grand scheme of things, you think about the quality assurance aspect of it. So are you obtaining medicines from a reputable source? Are they compliant to all the regulations? So, and those information, I included that in our pharmacy provision spec, simply because I needed to know that the pharmacy or the pharmacy organization are able to meet the set criteria that we've got in place. Like you said, Tammy, the organization that was providing your pharmacy, the pharmacy organization had to, withdraw simply because they didn't have wholesalers dealers license. Those are one of the main things you needed to have for an organization to be able to supply to another organization. They needed to have the wholesalers dealers license. But also for control drugs, those organizations need to also have the CD Home Office license. And it comes with a lot of criteria. It comes with a lot of, meeting set of standards that the Home Office would require them to have before having those licenses for that. And that would ensure that they're able to supply CD stock medicines for the supplying receiving organizations. So when you're thinking about, quality assurance, it has to meet all the standards. You have to ensure that you're thinking about all this and it's set stone. So although we from an organization, we went with our local acute, we also needed to know that the acute meet those standards as well. So we had to go through a lot of engagement, a lot of sessions, getting that sort of assurance within, from the organization that this is what they had, the licenses, and sharing those information for us to be able to do our due diligence within the organization. So that it's key that that's set in stone. I mean, of course, you have to understand that your patients don't really care about that. What they care about is them actually receiving their medicines. But there's some groundwork that needs to be put in place before you do that. Another thing you need to consider is the cost effectiveness. And I think, over years of me working in a community health trust, one of the major principles is the medicines optimization core principles that I had to embed within the organization. And one of the core principles is ensuring that medicines supply is cost effective. And everyone would probably agree with me that it's probably best that you're able to obtain medicines that is of quality, but also very cost effective, that also meets the NICE guidelines. So that's one of the things that we had to consider. We have, and that's we, from an organizational point of view, we had to set a stock list in place. That stock list meant that we were reviewing it at least twice a year. More often, depending on the service needs, it could be more frequent than that. But we had to review our stock list to ensure that the services we're ordering from that stock list and they're not going AWOL, because some of the services will rightfully tell you that the BNF has got all the medicine, so why can't we order what we need? I said, we need to ensure that we are working collaboratively with our other organizations in the healthcare, in the system, but also there are points of meeting the NICE guidelines and ensuring that we're compliant to that, but also ensuring that we are working within our healthcare partnership to adhere to the formulary. So that stock list is set stone there. And the good thing that we've done is also to put like a caveat with the one of the things that we need to consider. And then, I mentioned before the main stakeholders that you need to have discussion with. So having discussion with HR, having discussion, with finance, having discussion with a strategic team, having discussion with our contract team, procurement team was very key for us to be able to forge a right document. And for us, it was key for us, as an organization, even though I, as an expertise in pharmacy, I couldn't just go without involving these people. And that for us, I would simply say, procurement in the community health services, includes, that collaborative working. So you say you want to do it in silo. By all means, I had to own personal development, go and learn few linguals about procurement. I had to learn and understand the tender process. I had to understand few bits that I felt like it's needed for me for my own development. But I needed to encourage, to embed the skills of these individuals within my organization. And also the same thing would happen within the other, the procurement and the organization you're procuring the pharmacy medicines from. So those are the things that we need to consider as a set stone. So I think me joining my organization before, I never thought I would be a mini honorary procurement specialist in pharmacy, but it's been an exciting time going through various procurement processes within our organization. I'm just being mindful. Does anyone have any questions? So we're talking about pharmacy procurement and supply of medicines within community health services. Okay. No questions yet. You can, just signify and we'll bring you onto the stage. Another thing that we need to consider, and that's an example from our end, but then you need to think about those community health services that are affiliated with some bigger acute trust. Some, most of them, you probably don't know the difference, because they're probably having that sort of collaborative working. The workforce are probably, the mutual agreement is probably seamless, that you probably wouldn't be able to identify the difference. That is a simpler way of working, because then pharmacy provision, pharmacy workforce is being, it's seamless between the two streams, and you're able to gather enough support and enough guidance from a procurement point of view. So but that's it from us, really, from from my organization, my experience, and what we've had to set in place. I mean, it's one thing I must say, that it has been a learning journey for us, because there are certain things we did initially that having to go through another procurement process, I had to update my spec and also have a set KPIs that I'm able to measure the organization with, to ensure that they're not going AWOL, or rather we are not going AWOL with our request as well, and to maintain that contract and that relationship between both organizations. That's something that we do, and for me it's key. Developing those relationships is key, and that's how we've been able to sort of strike that working relationship and the pharmacy provision within our organization. So those are the things that you need to consider. By all means, I'm sure a lot of people would have other instant tips and ideas in terms of procurement, what they need to think about in terms of, some people would also have direct relationships with manufacturers or bigger suppliers, like Tammy does. I know some of my services and for medicines devices link up with us manufacturers directly, and that's because it's probably much cheaper, and we don't have to go through the rigmarole of wholesalers dealers license or procurement issue. And it was easier for them to maintain that sort of procurement process via the manufacturers directly. And, the procurement team handle that. So in all fairness, from a medicines management point of view, we don't deal with that. We only intervene when there's a supplier issue. Tammy?
Thank you so much for that. And, when you were talking, it just occurred to me that there are drugs that, even with good wills, we won't be able to supply to our patients. And those are drugs like what we call payment by results, or the drugs that comes from specialists to you. Rheumatology drugs, some oncology drug that, even though we are talking about getting drugs and everything like that, we are not permitted to actually get those drugs. We will have to get somebody to actually, we have to connect with the team. So for instance, if a patient is known to, for example, Royal Marsden Hospital, we have to contact Royal Marsden Hospital and say, can you supply us with those medicine? Because we won't be able to give the patient the medicine. Sometimes we have to ask the patient to bring it from home, because they are medication that was directly delivered to their home from the manufacturer. So it's about knowing the patient and having a robust system where the staff are able to tell you in a timely manner, this patient has landed on the ward, they are on this, what do we do? And I think that's quite important for that. In terms of the other thing I think would be more relevant to people is around like the pharmacy first and the PGD. That's another way people can obtain medicine. But then again, with the PGD, for example, you can only obtain medicine that are on the PGD, which is the patient group direction. Anything that is not on that list, the pharmacy or the organization won't be able to give it to you. And so, like when people say, but I want this one, why can't you give it to me? Or I want it in a certain, or I want it 2 tablets instead of 1. Why can't you give it to me? It's just that there are strict legal restriction around medicine that also mean that, we are not able to actively give the medicine in that way. And I think it's important to understand that. Future of medicine supply. Jenke, do you want to take that?
I will be happy to take that, but before I go into the futures of medicine supply, I think it's important to elaborate briefly about the supply of medicines via PGDs, because yes, we obtain medicine procurement, that's stock level, but there are strict rules and there's strict criteria that medicine supply can be done on the PGDs. And it's important as an organization that you have clear governance process for your PGD supply within the organization. You ensure that there is, PGD is one of my babies within the organization, to ensure that services are adherent to the PGD document, they're adherent to the PGD protocol. You understand that there's training in place for clinicians that are utilizing the PGDs, and also there are competencies or competency framework for individuals that using the PGDs, B, those that are developing the PGDs, and C, those that are reviewing the PGDs. And all these governance, criteria needs to be met for the PGDs to be before they can be supplied. And the caveat within community health services or a CIC is that our PGDs cannot be authorized internally. So we have to go to our ICB for you have to go to your authorizing board to be able to go those PGDs authorized, which means that timely review of your PGD is required, because if your PGDs do expire, within our organization, once the PGDs expire and they put it on the risk register, they can't use it, which means that we're now putting more pressure on the prescribers. So that timely review of the PGDs is key for medicine supply, for the continuity of medicine supply within your organization. So that's for PGD. To be honest, we can talk about PGD and it will probably take longer than an hour, but there are set criteria, there's set rules regarding PGDs. I don't, like Tammy said, there are specific, it's like the specificity of PGDs, which is the patient group direction, is to the, is very detailed. And it's important that, organizations have their set criteria, they have their documents in place. Basically, they've got all their ducks in a row, if I can say that. And another thing I want to also mention about PGDs is the ability to ensure that your organization have a PGD database to keep a tab of all your PGDs. For me, I found that very useful, because I needed to know that if my services, the needs are changing, the spec is changing for the provision or what they're being commissioned for, then I need to be able to review those PGDs to meet the criteria or to meet the needs of those services. So I've had services that I've actually stopped them from having PGDs because it's no longer required. So there's no point for them to have PGDs. A, they've had an increase in prescribers in these services. And B, there's another service that, there was no need. There was absolutely no need, because the patients they were seeing had, other, contingency plan for the supply of medicines. So it's about looking at requirements of those patient group directions in those services. Does that meet the need of the services at that time? So another point I wanted to raise before I go into future of medicines, and I think this is where I would like us to brew up conversation. But before I go into that, is there are other services that would also supply medicines via patient specific directions and via SP10s. Those are more stricter rules as well. So it's important that those services or the prescribers involved know exactly what their limits are. They're working within the scope of practice, and those are both the PGDs, the PSDs, and FP10s are auditable, because you need to make sure that there are no outliers, in terms of the supply of medicines. Future of medicines, that's, for me, it's a beauty. It's like a no-brainer of where we would like to see supply of medicines or procurement of medicines in future. I sometimes think that I say this, that if I can think it, then it can happen. So you think about future of medicines and you're thinking, how can we utilize, the current status quo in terms of the current, what has happened currently for medicines, and to ensure that supply of medicines is being adequately utilized across organizations. And the most important thing, that it meets our patients' needs, and there are no disruptions, there are no governance issues, and there are no general issues, if I can say that. And I say that the use of technology will aid better supply of medicines. I don't know if you agree with me, but I feel like, if we have a seamless, use of technology in terms of the ordering, in terms of the maintenance, in terms of, even to the point of, reviewing what's out there, I think technology plays a bigger role. In this day and age that we're in now, there is so much use of, technology, AI in medicines, and it's amazing what we can do. One of the areas that we feel like within my community health services is the need for us to jump on the bandwagon of the EPR, the EPMA system. And it will also be good, and think of me as being futuristic. It would also be good when you're able to link up with other organizations, and then, there's this conversation between one organization to the other, and they're able to monitor medicine supply that way. And I think that's what we can say about future. Being able to prescribe medicines, or being able to, order medicines without any delay. Tammy rightfully said that there are certain challenges that we face within the community health services. So, like specialist medicines that are being obtained or, delivered directly to patients' home. If there is some sort of technology that could discuss that there's a patient in the community health hospitals, those medicines, everyone are being, there's that rightful communication across the streams. And for me, it's about better supply of medicines. It means that everyone, you can actually audit trail it, and that was the idea of having the FMD, the Falsified Medicines Directives, which has been discontinued in the UK simply because we are no longer in the EU. But something similar will probably can then be adopted within the UK, where we can then, from a start point to the end point of a patient, you can actually track that. And why is that? It means that patients can then be assured that they're getting their medicines from the right source. There are so many sources out there. There's so many, I'm sure, a lot of communications out there. It's even mostly for the controlled drugs that they're, counterfeit medication out there. And it's important that, when we have a robust technological system in place, the ordering of medicines, the supply of medicines, and the monitoring of the medicines used will be better. And I wanted to just give an example. And I say that because if we look at the Gosport report, one of the things that you consider for Gosport report, when there was an increase in demand of controlled drugs, but no one was monitoring that. Imagine if we had a very good technology system where we can actually monitor that there's been a spike in ordering of controlled drugs within a particular organization. Then you can be able to deal with the reasons why medicines when the medicines request or medicines order is increased, and then you can then be able to know where it's going to, which patient is going to. Is it really required? Is there a need for them to be an investigation? Is there a need for us to review our procurement processes to see what we can then put in place? Like I said, this is the future as I'm speaking. Some organizations are probably working on it, but community health trusts are still a work in progress. And that's what I can see happening in future, that we're able to utilize technology for the benefit of community health trusts. It's a challenge, but it's also an innovation for us. And like I said, it's a work in progress. I feel also we can use technology to monitor adherence within within our organization and neighboring organizations within the system. So when you're able to procure, and I think the beauty is you can still monitor what's going out from the EPAC system, but when you're able to monitor stock medicines that are going out from the acute or any other provider organization to the community health services, you're able to understand what the influx of medicines, the use of medicines within the community health trust, and that data will be readily available. I think that's one of the areas that is quite lacking at the moment, because you can't get those data because those information are manually generated within organization, and it's not out there in the public. Unlike when you have prescriptions, the FP10 prescriptions that are then that goes through the database, the NHS BSA database, and then you see for the likes of the EPAC data that is nationally, you can look at the trends of medicines used in different areas, in different ICBs. So I think for me, when I think about future medicines, this is what I think about. And I believe that, there's still a scope on how we can develop medicines use within community health services. And I believe that, the use of technology will be vast. And then we're thinking about even, tightening the process of ordering. You're able to control that better with technology. So it's like, watch this space, and I'm quite excited about what's the future brings, or what the future holds for us in healthcare, in the healthcare sector. Does anyone have any questions, any queries?
Thank you so much. Thank you. And I think really digital is the way, because all the information can be joined together, and we can all be using the same system, looking at the same patient at the same time. And, like you said, we can easily say, oh, your patient is here. Can you send that sort of thing, for the ones that we've talked about, that we cannot just order the medicine, and for people to be able to know how, even for patients to get timely information about their medicine. I think that's important as well. Wow, we are over. Thank you so much, Esther, for staying with us. We are so grateful for your time, and we do not take it for granted that you stayed all the way with us. Thank you so much. We will obviously put out again what we're going to be doing for next month, in terms of medicine management within community health service. And we're hoping that you'll be able to join us again, same time. Obviously, every second Tuesday of every month, which will be in the month of April, May. No, sorry, June. Look at me. Thank you. You should have corrected me. In the month of June.
Probably still
Any
stuck in April.
any last word? Thank you.
I obviously I echo the acknowledgement of everyone that has been able to join us today, everyone that has stayed behind. But also, we are also open to ideas of what you would like to know more within community health services. What areas that you feel like actually community health services could work on from a pharmacy point of view, and being mindful that there are areas that organizations would, individuals will probably want to improve on generally. But from a pharmacy point of view, I think we need to be able to work together here. So we are open for ideas, but also we can make it a better and a richer conversation. So even if it means that conversations we're having like this can then mean that we're having to invite speakers that are probably specialists in the area, we can then start looking into those conversations. But I think it's good that we're starting this podcast and we're having this conversation. So I'm really excited for what's yet to come in the month of June.
Definitely excited. Looking forward to the month of June. And like you said, if people want us to invite somebody on this particular topic, we're open. We've been open since the beginning. And I think the second topic we treated was suggested by somebody in the audience. So if you have a particular topic, even if you did not attend this particular audio session, you can leave it in the comment section, and then we are looking at it and we will act on it. So thank you so much. Before we run over too much, thank you, and we'll see you next month.
Thank you, everyone.
All right. So we close the room in 1, 2, 3.